Checkmate 142 was presented at the GI Symposium back in January. It was a randomized study comparing nivolumab and ipilimumab to nivolumab alone for heavily pretreated patients with metastatic MSI-high colorectal cancer. Patients who received the combination had a 55% response rate with mostly partial responses and had significantly improved progression-free survival and overall survival at 1 year. It suggests that the combination is a promising regimen for patients with MSI-high colorectal cancer and metastatic disease.
Perfect. Okay, next question. How does tumor-sidedness impact your colorectal cancer treatment algorithms?
For patients with metastatic disease, I start with the right-sided tumors. There's really no data to suggest that even for patients who are RAS wild type and RAF wild type, that we should be using EGFR-directed antibodies in that group of patients with chemotherapy. Those patients typically receive chemotherapy and, if a candidate, bevacizumab. Left-sided tumors are more complicated. We have data that suggests that adding EGFR inhibitors to chemotherapy in patients with left-sided colon tumors have better outcomes, but they also have the unique dermatologic toxicities that can be distressing to patients on a first-line therapy. Overall, I would say I still use more combination chemotherapy and bevacizumab for my left-sided patients.
Great. Okay, next question. Should FOLFIRINOX be used in an adjuvant setting for patients with resected pancreatic cancer according to the PA6 clinical study?
We will hear more about this trial today. This study compared modified FOLFIRINOX to gemcitabine alone, a standard of care in patients with resected pancreatic cancer. The endpoints of the study were quite exciting, including a 4.5-year survival for the patients who received modified FOLFIRINOX. Questions that will need to be answered are what type of patients were enrolled in this study and how these results will translate into the community. But certainly this represents an improved and possibly standard of care for our patients with resected pancreas cancer.
Sorry. Okay. Next question. Given the results of the PREOPANC-1 study here at ASCO 2018, should resectable pancreatic cancer patients go to immediate surgery or get preoperative chemotherapy first?
In many centers already, patients are receiving neoadjuvant treatment before surgery. This is the first data set that really addresses that, and this does suggest a benefit to neoadjuvant gemcitabine alone and in combination with radiation therapy prior to surgery. For the patients who received preoperative therapy, they had a similar resectability rate to those who went to immediate surgery, but outcomes including survival and relapse-free survival were improved in the group that received neoadjuvant treatment. Questions to be answered, I think, are how the dose of gemcitabine, 1,000 milligram per meter squared, with radiation can be handled by patients in the community, and how this regimen would compare to FOLFIRINOX.
We have time for one more. Do you want to do that first one on immunotherapy?
Yes.
Okay, let's try that one. So do you agree with the headline, immunotherapy now standard for some patients with colorectal cancer here at ASCO 2018?
I would agree with that headline. Patients with MSI-high colorectal cancer and metastatic disease, after they've received standard chemotherapy, I think are candidates for immunotherapy. Right now we have 2 FDA-approved drugs with nivolumab specifically for colorectal cancer and pembrolizumab for patients with MSI-high tumors. We mentioned earlier the combination data of nivolumab and ipilimumab, and I think immunotherapy will become more of a standard for this group of patients moving forward.
Great. Perfect.
Wow, that was really good.
Yeah.